Thank you for the introduction. I'm today sharing my experience in active surveillance, especially nurse-led active surveillance and supported self-management in that pathway for our prostate cancer patient. So today I'll be covering our prostate cancer stats in Cambridge, and the protocol that we use are stratified cancer surveillance protocol, which is STRAT-CANS protocol, and the process of establishing nurse-led surveys for prostate cancer pathway, and how did we establish the patient eligibility for the nurse-led clinic, and planning the patient's education session and delivering that ongoing support for patients through telephone or using our MyChart system. Also, patients' experience and challenges and barriers of developing these surveys, and next steps, what I would like to see how this survey is developed. And then I will summarize and share some take-home messages. So this slide is about cancer incidence, and I'm sure all of you are aware of this. So prostate cancer is most common cancer in men and second common cancer in UK. And about 52,000 men diagnosed per year. So as you know, there is a lot of awareness and initiatives which then encourages men to go and get tested or have a PSA and then eventually get diagnosed. And majority of the time, this is early diagnosis of low-risk prostate cancer. So, it is really important what we do from that point of diagnosis. And to support that, NICE has updated their guidance. So NG 131 advice on CPG1, which is the Cambridge Prognostic Group 1, if patients on CPG1 offer active surveillance, and if they are CPG2, they have a choice of active surveillance and the treatment options, and if it is CPG3, consider active surveillance, especially for those men who are not keen to start the treatment straight away. So then, our active surveillance numbers were increasing when we did the audit, because we started using the tool and supported decision making, and that initiated further discussions. And also the initiative from Macmillan about establishing risk stratified pathways and recovery package. So we have decided to do the risk stratification in all the prostate cancer pathway, or the treatment pathway, including active surveillance. Yeah, so stratified cancer surveillance, which is STRAT-CANS journey, this has been discussed in the same platform here under Prostate Cancer UK by Professor Nana Pragasham and David Turtle before. Therefore, I'm not going to go through that in details. Briefly here, initially the STRAT-CANS were trialed in our research setting, which then published in 2017. In 2018, this was presented to our Regional Cancer Alliance and our local cancer board and gained approval. At the same time, we were establishing the recovery package and risk stratification, which then helped in terms of mapping the pathway. In addition to that, in 2019, we undertook an audit of our new diagnostic clinic to understand the treatment decisions from patients and how many patients, which group opting for what kind of treatment, showed an increasing number of patients on active surveillance. This initiated a capacity management discussion, and then leading to developing a nurse-led a proposal for a nurse-led active surveillance clinic. So establishing a nurse-led clinic, so just the process of this, which StratCans groups are suitable for nurse-led clinic, and then gaining an agreement from the local clinical team for the nurse-led clinic, and approving an SOP and agreement then approved and signed off. Then the actual nitty-gritty of the process is getting a clinic code set up using, CMR or clinic methodology request form, and alongside that, the nurse training to ensure the confidence and the knowledge base there to run this clinic. So in CUH, this is part of our pathway, which is, I cut out a few boxes just to be clear in terms of, from the diagnosis, what we do to support men from diagnosis. So part of my role is diagnostic as well. So we do nurse-led triaging, nurse-led 2-week wait clinic, and we support co-chair MDT as well. Then once the patients are diagnosed at the diagnostic clinic, patients are informed of the result by a consultant and specialist nurses, and the nurse will then continue with the support in terms of information provision and so on. And then patients are sent away with the information pack, including Predict Prostate and East of England information about information on NICE guidelines and things like that. And then specialist nurses intervention means that there is a telephone consultation booked a few days after their diagnosis, once the patient had a chance to read the information and digest the news. And then at that point, we use this CPG to discuss the risk of prostate cancer versus risk from other causes, and then help with that supported decision making. And once patient made that decision, majority of the time patients make a decision at that appointment, but some patients would like to have a face-to-face discussion, or they may need to have some help with using Predict and things like that. Then we will arrange a face-to-face appointment. Otherwise, majority of the time patients made a decision at the end of that discussion. Sometimes it can be half an hour or 40 minutes discussion, just to make sure they are clear what they want to do and understand the side effects of the treatment, or risk and benefit as well. If the patient then decided on active surveillance, they are booked onto an active surveillance clinic, which is a consultant-led clinic, and then they have given their plan. So which StratCans group they're going on, or how often they need the PSA. So they have a plan in place. So for active surveillance clinic, consultant-led clinic, and we do book them back into the nurse-led active surveillance seminar, which is a monthly seminar currently on Zoom or Teams, which is then patient are sent the link and joined online. After this, then patients are booked into either consultant-led clinic or nurse-led clinic according to their clinical group on the StratCan pathway. StratCan groups suitable for nurse-led services is mainly the low-risk patients. So we started with the CPG1 with PSA density less than 0.15 and no lesion or Likert 2 lesion. So that will give you then confidence in terms of having that discussions and supporting the psychological support and so on. So we then, the group is then changed into the 1B is when there is a lesion present. So both 1A and 1B is nurse-led clinic, and 2A is CPG2 with no MRI lesions present. So that that is a group that I'm starting to see as well. So we have a process where consultants see patients for a period of time and repeat biopsies or restaging. And if they stabilizes on surveillance and happy with surveillance, they moved into nurse-led service as well. And see Start Cans group 2B and 3 mainly consultant-led clinic. And this is our protocol. So we mapped the pathway, planning, including the recovery package and holistic need assessment as well. And then the group 1A to group 3, and how often they need the PSA, and mainly the appointments and the MRI scan interval varies, but PSA mainly 3 to 4 monthly. And then mainly telephone clinic, some face according to patient's request, and MRI interval changes between 6, 12 or 18 months. So we have some support for patients, as I discussed. Is the first one is the patient seminar, which is an online group session that run by specialist nurses and cancer navigator. So we go through a bit more in details of active surveillance. So what evidence are there? So some evidence about the CPG and comparison of other risk, as well as prostate cancer risks, comparison studies. So we show them some of those results and go through and explain that to them. And also expectations. So what are we expecting from patients? So what is their responsibility as a part of their own follow-up? So making sure they understand what PSA is, what is it needed. So PSA is a prostate-specific antigen. It is not cancer-specific antigen. Therefore, it can increase if we don't do anything. So, but the rate of increase and the changes, that is what we are monitoring. So we give that information to inform patients, so they are empowered and they are confident in their follow-up plan, and giving them that responsibility to take that ownership of their care by doing the PSA and taking part. So we advise patients to have their PSA every 3 months. We give them a threshold of PSA to inform us. So if the PSA goes above certain level, then to contact us. So mainly contact me. So patients are confident and they know what their PSA is, they know who to contact. So those kind of help and support available. So that's what we do there. And the aim of the session is to empower men to take part in their own care. And then the PSA blood test, I don't know how you all have issues. We have problems in terms of organizing PSAs at the GP practice because of the capacity. Luckily in Cambridge, we are, during COVID time, we opened one of our park and ride. There is a drive-through blood test, which is luckily still open, and patients are going there. So we put a standing order on our Epic system and patients go there for their PSA. And then MRI according to the interval, according to their STRATCAN groups. And appointments are mainly telephone clinic or face-to-face, depending patient's preference. And the prostate biopsy. So after the diagnosis, if the patients are, there is a slight doubt in their risk classification or biopsy result, or any remaining, sort of question about their diagnosis, we definitely recommend a biopsy within the first 12 months. We used to do that often if we diagnosed by TRUS biopsy, they will have a general anesthetic transperineal biopsy. But now we don't do any more transrectal biopsy, so it's mainly transperineal biopsy. So if we are doing a repeat biopsy, we do a general anesthetic transperineal biopsy for confirmation within the first 12 months. And then after, if they are then on the same risk category, then they will continue on to the long-term program of StratCans and self-manage their PSAs. So with regards to other patient support, the specialist nurses support is mainly telephone support. As it is not an active telephone support. We have answer machine service where patients are informed that if you call, it will go to an answer machine. You leave a message, and we have a CNS admin team supporting that, picking up the message and informing the relevant specialists. We also have a MyChat functionality on Epic, which is a system, a patient portal they can log on to and then access their records. So that records they can access is their demographic, their medications, their blood test result, the scan result, and the histopathology result. And the other functionality there is the contacting the clinical team or admin team. So they can contact their admin team if they want to move the appointments and things like that. They can contact the specialist nurses or the clinical team if they have any clinical queries. So patients leave a message. So we will check the messages in between clinics and you can reply. And majority of the time, if it is active surveillance patients, it's usually very quick message. Some patients would say, my PSA gone above the threshold, what do I do? Or some patients says, oh, my PSA went above the threshold, but I have arranged another PSA in 4 weeks' time. I'm just letting you know, I'll get back to you if I need to at that point. At that point, I would respond to that message to say, oh, thank you very much for letting me know. Well done. Let me know if it is still above. I won't ignore that message because they said they will contact me later. So they are reassured that I have seen the message and there is nothing else for me to do there. I'm happy with what their plan. So that helps patients and give them that confidence as well. Yeah. The other tool we use is called Track My PSA. It's a software. Patient need to log on and register to have an account. They can give a read-only code for us if we want to log on to have a look. But patients can register. It's really straightforward there, where they can put their details and their histopathology result, how often they need PSA test, what is their PSA threshold, and set reminders for their PSA test and appointments and things like that. So when they are due for a PSA, take in 3 months' time, a few weeks before, they will get an email to say that your PSA test is due such and such date, and then patients normally able to organize that. So we use that literally in majority of our clinics. Other support we give is, as predict prostate and prostate cancer, knowing your options. So it is really important that patients make an informed decision and they are happy with whatever decision they make, rather than because we said or nice advices of this, I'm going for this option. Rather than that, inform the risk and benefit of each treatment. So we guide them to the prostate cancer, knowing your options and predict prostate. So it is signposting. Especially, we don't have time to go through that with all patients. So all the patients get the information given to them. So predict prostate, anyone can access, and we give the clinical details they need from the first clinic of their prognosis, and which give them an sort of information about their risk from the prostate cancer as well as the risk from something else. So it is really important for them to understand that. And what I'm seeing is patients then, when they understand your risk of dying from prostate cancer, especially the early prostate cancer, is maybe 2%. but your risk of dying from something else, 20% or 30%, depending on your age and other comorbidities and things like that. So that will help patients to put things into perspective when they make that decision, to see, do I really want to put myself through this? So sometimes that decision making is really, really important from my point of view, because then that give them that information they need. And then when they look up the NICE guidelines, they feel reassured and understand why NICE is recommending this or we recommending this. So knowing your options website, we give a leaflet look like this on the screen, and when we give the information, I put the grade group or Gleason scoring and PSA reading and the staging on a piece of paper, and they will go home and use it. So that is another way of informing them about their options. So that take me to the challenges and barriers of getting the research into practice. So all the the methods how you do it, the research, and then to making sure the evidence are sort of valued and reviewed, and making sure we review against excess and policies and all other information we have, and considering that all that evidence behind it, how we tailor that to the patient's circumstances and the patient's experience or preferences. What is the patient's want, rather than we saying, okay, there is an evidence here that this kind of cancer doesn't change, so you go on to active surveillance. So we we only, if we see patients who are anxious but really want to stay on surveillance, you have to tailor their care accordingly. So helping them to make those decisions, supporting them and reassuring them is really important as well. And then, as you know, that when you have lot of strong clinical team, there will be questions and agreements and disagreement to ensure that we provide the survey safely. So there was a lot of meetings and discussions to get that agreement. And then when it comes to nurse-led, to consider what is safe for the nurse-led clinic, and how we can provide that for the nurse-led clinic in terms of supporting specialist nurses as well. So that was something, agreeing which group is suitable for specialist nurses was something we did as well. And learning and building confidence. So I do the active surveillance clinic at Cambridge. So I'm talking about myself, so apologies if it may sound strange. But as a specialist nurse, we all learn things. We are not trained to do all this clinical side. We are trained to care for patients. So I had, that issues. Okay, if patient says something, how do you then reiterate that the policy says or the evidence says? How do you communicate that? Am I able to do that to reassure patients and things like that? So there was a lot of things I did initially at the early part of my career to improve myself learning. One of the things I did is Prostate Cancer UK funded masters in prostate cancer care, which was really, really helpful and helped me to gain that confidence and knowledge base. So using that experience and skill, and then thinking and changing my mindset when I see follow-up patient after treatment, okay, they don't have a PSA. If they have a PSA, there is a problem. 2, active surveillance. Okay, this patient have a prostate there, hasn't had a treatment. Therefore, they will have a PSA, but we need to look into the PSA density, all those things that you need to be aware of. So that was something that I needed to, change my mindset too. So when you do a treatment follow-up clinic, all patients are same. So if you are doing a mixed clinic, then you need to change your mindset of which patients, and you need to be really sort of switched on to when you review all the clinic, all the patients, because of the different group of patients. So I was in my follow-up clinic, I usually get patients with elevated PSA, patient who is on hormone treatment, and watchful waiting. So I had some of that skills already there. So this is just making sure, active surveillance, the patients are eligible for an active treatment. I need to make sure that, I support them and we do the right thing in right time, so they are still eligible for an curative treatment, and we don't. That was the main worry I had. But it helped, doing it and following a protocol. That was something that very reassuring to me. So it was straightforward. It is written there how often I need to do this. And if you see something different, you are an experienced specialist nurse, you would question, you would go back to the consultant and say, I didn't feel right. This is like this. Because not all patients fit into all criteria. So there'll be some outliers. We need to address it that way. And, to be able to do that, I had very good support from consultant team. All of my consultants are really approachable, and I can go to them and ask, okay, this is something I'm not quite sure. Can you advise? So, another important thing is we keeping ourselves updated and our knowledge base as well. So if you see a practice different or, not quite right, what is right. So you can question that. So that kind of confidence was really important as well. And other thing I noticed is, if as a healthcare professional, if we are not confident when we are talking about something to the patient or giving a treatment decision and supporting them to make that decision, that confidence level reflects on to patients. If you know your facts and figures and evidence and you know what you're talking about, then the patient feels that confidence. That will help as well. So that is the main thing I needed to do for my clinical skill-based side of things, to upskill myself to provide the service. And then approval process. The main challenge was the CMR form, this clinic methodology form, which is a form that goes to the commissioners. So if you ever doing this, your ops team should be able to help you with that. But the CMR form, which the commissioner is looking for, especially, mainly the funding, how much money you are making by doing this. So when you change from consultant-led clinic to nurse-led clinic, there is a financial loss. So they'll reject it. So I had it rejected. So we sent back again to say it's free up consultant time and we need to have capacity management, all those kind of things. Still wasn't right. So then we changed the wording to say that it is a consultant-led clinic, but provided by the specialist nurses. So the tariff remains the same as consultant-led, but as the specialist nurses doing it, we are slightly cheaper. So, it worked. It took nearly, a year just going backwards and forwards with this. So that was frustrating, but that was, all done. And job planning was another challenge, I would say, because I do diagnostic pathway as well. So that was the priority, especially with the faster diagnostic standard, 28 days pathway, making sure you are timely seeing the patient and responding to their, results and things like that, and all that commitment, and then finding that time in my job plan. However, we managed to juggle the clinics, and I do a clinic weekly Friday afternoon. So that was that was something that I need to organize myself, in other words. We had really good feedback from patients So patients felt knowing their follow-up plan is a threshold, give them confidence in their own decision to have surveillance and reduce worry about living with a cancer with treatment. Other patients said what support available and who they can contact and how to contact was really helpful as well. So this is something I hear a lot from patients, knowing what I need to do and what support available, how I can contact the support or who I can contact was really, really helpful. And one patient said he felt in control of the situation as he knew what to expect from the team as well as him, which is even that control rather than, as healthcare professional, we always like to say, I'll do it for you, I'll do this, I can do this. So rather than that, just giving them that control back was really good. That's what some patients felt. So that brings me to what is next. So I would like to change the way we give the patient seminar. So recording it and then signposting patients to watch it at home, and then arranging a session like a Q&A session or something like that monthly, depending on the need, will be something I would like to aim for, so that patients who is not quite don't want to come online or not sure about online usage will be comfortable watching it at home and then understanding and then asking, able to ask the question as a group or contact me separately. And then the main thing is training and succession planning. So we have, as we all have staffing issues, 2 of us, and I got a third member of staff just returning from maternity leave. So 3 of us manages the whole of the prostate pathway. So we can then half my role in management as well as leader. So between us, then we all of us have the same competencies to provide the nurse-led service, and then we getting our structure in terms of succession planning as well. That will be something that I'll be working on. So in summary, StartCans offers a safe method to risk stratify active surveillance. A nurse-led surveys then demonstrate using the right resources in right place. So informed decision-making support and patient seminar improved patient compliance, and patient seminar helped supported self-management and reduced number of patients contact. So reduced here as well. So which was really helpful, especially with the staffing issues and our capacity. That was really helpful. So thank you very much. So my details and contact details there, and I want to just pass my thanks to Professor Vincent Nanapragasham for all the support, and my urology consultant team and urology booking team at Cambridge University Hospital to helping me to make this happen. Thank you very much.